Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. We were discussing about the neoplasms of the stomach. Yesterday, we learnt about the etiopathogenesis, clinical features, and investigations of carcinoma of the stomach. Now, let us study about the remaining aspects of the carcinoma of the stomach. The management. The treatment of cancer of stomach depends upon the stage of the disease. Already we discussed about the concept of cancer treatment when we were talking about the pancreatic surgery. Curative surgery means a radical surgery. That means when we can remove the whole of the tumor in the body, that means not only in the organ, but also with the organ and its draining lymphatic field. That means the whole lymphatic field has to be removed so that even those microscopic spread of tumor cells into the lymphatics and lymph nodes will be extirpated. So that by that we can expect a cure to the patient. That is why this is called the curative surgery. So whenever you are planning to do a curative surgery means you must be always radical. So this is done when the cancer is loco-regional without any metastasis. So when the lesion is confined to the organ without spread to the nearby organs or distant spread, then we can do this particular procedure of radical surgery. Palliative surgery. This is done as a symptomatic treatment when the cancer spreads systemically. Because when the disease has spread widely, though you remove the mass by doing a big surgery, the patient is not going to benefit because he will have the problems with the metastasis. So, whenever there is widespread metastasis, the treatment is only palliative. That means whatever symptom the patient is suffering from, that symptom is attended to. So for the treatment's sake, we have to divide the disease into early stage and advanced stage. So early and advanced, how to make the staging? So stage 1A means it is T1, N0, M0. Probably you know what is meant by T1. What is T1? What is T1 lesion? When do you call carcinoma stomach as T1? Yes, when the tumor has spread up to the submucosa, then we call this as T1. So stage 1A means T1, N0, M0. Stage 1B means T1, N1, M0 or T2, N0, M0. What is T2? What is T2 tumor? Yes, infiltration to the muscularis is called the T2. Stage 2 disease, T1, N2, M0 or T2, N1, M0. What is N2? 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 What is N2 Nodes, yes, what nodes? How many nodes should be there? Not distant nodes. This end staging is done depending upon the number of nodes that are involved with cancer. If there are 3 to 6 nodes, then we call it as N2 nodes. Yes. Stage 3 means T3 N2 M0, T4 N1 M0. What is T4? What is T4 lesion? Yes, the tumor which has infiltrated beyond the serosa into the adjacent viscera. That is called the T4. Stage 4 means T4 N2 M0, NET N3 M0. That means if N3 is there, we call it a stage 4, irrespective of the T staging. Or NET, NEN, if M1 is present, then we call it a stage 4. So it is literally difficult for undergraduate students to remember the staging. So what they can remember is stage 1 and 2 means the disease confined to the stomach wall. It has not breached the serous coat, and lymph nodes are less than 6 in number without any metastasis. All the other are the advanced stage. So that way you can remember it. So the operable tumors, that means where the tumor can be removed for resection, for curative resection. Stage 1, 2, 3 are operable tumors. Signs of inoperability: when the tumor fixed to adjacent organs which cannot be resected, liver secondaries, peritoneal secondaries, Krukenberg's tumors, supraclavicular nodes, rectal shelf of Blumer, more than 15 enlarged nodes discovered on CT or endoscopic ultrasonography. That means N3 nodes. The goal of curative surgical treatment is resection of the all tumor-bearing tissue. This is also called as R0 resection. The type of radical surgery depends upon the site of the tumor. For upper two-thirds tumors, the surgical procedure is called the radical total gastrectomy. For the lower one-third tumors, the surgical procedure is called the subtotal radical gastrectomy. Neoadjuvant therapy, neoadjuvant chemotherapy is helpful in most of the cases, especially for stage 3 disease. What will happen if you give neoadjuvant chemotherapy for stage 3 disease? What will happen if you give neoadjuvant chemotherapy for stage 3 disease? What is the role of neoadjuvant therapy? Why we give neoadjuvant therapy at all? What for we give neoadjuvant therapy? Yes, you are right. It is downstaging. Downstaging means what will happen? Stage 3 disease, what will happen? Neoadjuvant therapy is not for palliation therapy. neoadjuvant therapy is given. For example, stage 3 disease is there. Stage 3 means even T4, N0, M0 is also stage 4, stage 3. So you want to do resection. That means the tumor has spread beyond the serous coat. But because there are no lymph node involvement, there are no metastasis, you plan to do surgery. In this case, if you give chemotherapy before surgery, after 4 or 5 weeks, if you examine and do a CT scan, you will find that the T4 has become T3. That means the serosal, extraserosal spread has been relieved. So the patient is having only tumor confined to the muscle coat. That means it has become a T3 lesion. So once it becomes T3 lesion, it becomes stage 2 disease. So what you are doing here, you are downstaging. So a stage 3 disease will become stage 2. So then it becomes easy for the surgeon to operate. So neoadjuvant therapy is given. Of course, you told many things like palliation, prolonging life, etc., etc., etc. Of course, the objective is only to prolong life. But the principle of neoadjuvant therapy is whenever there is some locally advanced disease, you give chemotherapy or radiotherapy that will come down. So, which is considered to be either to an inoperable case can become operable. So, neoadjuvant therapy will be helpful to reduce the downstage disease. So, stage 3 disease becomes stage 2 and it becomes now easily operable. So, the operable tumor management, for example, the tumor is there in the upper 2/3 of the stomach. You have to do total radical gastrectomy. That means total gastrectomy has to be done. It should be radical. When do you call a surgical procedure as radical? When it includes the lymphatic draining tissues also. That means all the tissues bearing the lymphatics draining from the stomach, that should also be included in the resection. So we have already seen the lymph nodes draining the stomach. They will be along the curvatures, they will be along the blood vessels, they will be along the origin of the main vessels like celiac, superior mesenteric arteries. So what you must do, you must remove all the tissues in this area. So you have to remove the lesser momentum along with the blood vessels, along with the lymphatics and the lymph nodes which are there along the lesser curvature, the lymph nodes which are there along the major arteries. So they should all be removed. And here spleen, if it is near to the spleen also has to be sacrificed. And greater momentum has to be removed. So that is radical. Radical means remove the tumor along with the organ, plus the lymphatics bearing tissues. So for these lymphatics, wherever they go, because you can't see the lymphatics, that's why you can't remove the lymphatics. What you do then? So you presume that the lymphatics are going in this pathway. So you remove all that tissue. So that is radical. So total radical gastrectomy if the tumor is confined to the upper 2/3 of the stomach. If it is confined to the lower 1/3 of the stomach, you do lower radical gastrectomy or subtotal radical gastrectomy. Of course, 6 centimeters proximal to the palpable margin of the tumor, you have to resect the stomach. So this bit of the stomach will be removed in case of subtotal gastrectomy. In case of total gastrectomy, the whole of the stomach is removed. This is done in the patients with stage 1 to 3 in a fit patient. The goal of curative treatment is resection of all tumor-bearing tissue. The type of radical surgery depends upon the site of the tumor. Already I told you. Radical total gastrectomy. Indications: upper 1/3 tumors and upper 2/3 tumors. You can say upper 2/3 tumors. The following structures are removed en bloc: the whole of the stomach and lower 2 centimeters of the esophagus, entire greater momentum and lesser momentum, and lymph nodes are removed in continuity with the stomach. Subpyloric suprapyloric nodes, hepatic group of nodes, nodes along the lesser curvature, along the splenic artery, along splenic hilum and around esophagogastric junction, with or without the spleen and tail of the pancreas, depending upon the proximity of the tumor to these viscera. If the tumor is nearer to the tail of the pancreas, you remove tail of the pancreas and spleen also. If it is not nearby, you can spare them. The anastomosis is achieved by Roux-en-Y esophagojejunostomy. You keep the patient, if the patient is very obese and stomach is steer horn, that means the patient is hypersthenic. So then stomach will be broad and wide. So it will be, most of it is under the rib cage. So through abdominal incision, it will be difficult for you to access the esophagogastric junction and to dissect at the splenic hilum. So in those cases, what you do is you go for a thoraco-abdominal approach. Thoraco-abdominal approach. Usually a long midline incision will be sufficient. So the structures to be removed are the lower 5 centimeters esophagus, the whole of the lesser momentum, along with the lymph nodes, then whole of the stomach, including the spleen, the greater momentum, and the lymph nodes. So all of this mass is removed. So once the stomach is completely removed along with the tumor mass, then you do the Roux-en-Y anastomosis. Already I told you how to do this Roux-en-Y anastomosis. Radical subtotal gastrectomy. Indications: lower 1/3 tumors. Procedure: tumor bearing stomach with 6 centimeters of clear margin is removed en bloc with other structures as in the radical gastrectomy. Anastomosis, Billroth 2 anastomosis. What is Billroth 2 anastomosis? What is Billroth 2 anastomosis? What is Billroth 1 anastomosis? Billroth 1. Yes, very good. Billroth 2 means it is partial gastrectomy followed by gastrojejunal anastomosis. Billroth 1 means gastrectomy followed by gastroduodenal anastomosis. So you can do Billroth 2 anastomosis, or you can do Roux-en-Y gastrojejunostomy as bile reflux is high after Billroth 2 anastomosis. So the curative treatment is applicable only for the operable cases. Operable cases means where the tumor has not infiltrated beyond the stomach, where there is no involvement of the lymph nodes, and where there is no distant metastasis. So such cases you go for curative resection. Curative resection means for upper 2/3 tumors, it is total radical gastrectomy. If it is for lower 1/3 tumors, it is distal radical gastrectomy. Palliative treatment is given for all the other cases. When do you give palliative treatment? If there is obstruction or bleeding for the stage 3 or 4 tumors. For pylori growths, so what will be the symptom? Patient is having carcinoma of the pyloric antrum. It is not operable. It is inoperable tumor. So when do you do surgery? That means what should be the symptom or troubling symptom for the patient? Yes, it is the pyloric obstruction causing vomiting, projectile vomitings. So the patients will have gastric outlet obstruction. So what you should do? You should relieve that obstruction. So just imagine and tell me how best you can relieve the obstruction by surgical methods. There is a mass in the pyloric antrum blocking the lumen. Food cannot go into the duodenum. So now how do you manage this case? Yes, the simplest thing is to do a gastrojejunal anastomosis. So the options being lower partial gastrectomy with gastrojejunectomy, Devine's exclusion gastrojejunectomy, and anterior gastrojejunectomy. So this is lower partial gastrectomy followed by gastrojejunal anastomosis. Why do you want to do lower partial gastrectomy? It is a palliative surgery. Why do you want to do gastrectomy? The reason is, if the tumor mass is there in the stomach, it secretes or it produces a lot of necrotic material. This necrotic material, when it comes into the lumen of the stomach, it causes one type of gastritis, and patient doesn't have the appetite to eat food. So his anorexia will continue if the mass is there still in the antrum. That is why, for example, the patient is having pyloric antral growth and liver secondaries. You don't do curative resection, but what you do is you just remove the mass. That means you remove the pyloric antrum with the mass and do gastrojejunectomy. If the patient is fit, then the patient will have a complete relief from the symptoms of obstruction, as well as he will regain his normal appetite for the time being. How long? Till the metastasis kill him. That means for a few months, whatever period he lives, he will be comfortable. So that is lower partial gastrectomy with gastrojejunectomy. Pyloromyotomy cannot be done at all. Pyloromyotomy, because here you have to cut through the tumor. The tumor is there in the mucosa and has infiltrated through and through the whole wall of the stomach. If you cut it through the tumor tissue, you cannot suture it. Tumor tissue won't hold the sutures well. There will be definitely some leak. That is why pyloromyotomy is not at all the treatment for a case of pyloric obstruction due to tumor. Pyloromyotomy is the only treatment advocated for congenital hypertrophic pyloric stenosis. Then Devine's exclusion gastroctomy, gastrojejunectomy. If the patient is unfit for surgery, for resection. Resection means it carries some mortality. So if the patient cannot withstand resection, then what you do is you just transect the stomach there, suture it there, and do the gastrojejunal anastomosis. So this is called excluding the tumor from the stomach and GJN. So by that, the tumor necrotic material will not come in contact with the stomach. That is why the anorexia and nausea will not be there. Anterior gastrojejunectomy. For the duodenal ulcer, what did we do? What type of gastrojejunectomy we did? We did posterior gastrojejunectomy. Posterior gastrojejunectomy is always ideal because the duodenal junction is quite near to the posterior wall of the stomach. When you want to do a gastrojejunal anastomosis without a loop formation, now you can see here this is anterior gastrojejunectomy. So here is the duodenal junction, here is your anastomosis. So a big loop of jejunum is hanging here. This loop will produce a lot of problem. I will explain those problems when we talk about the sequelae of gastric operations. So it is always better to do the anastomosis as close to the duodenal junction as possible. That is why whenever you plan to do a gastrojejunectomy, you always do only posterior gastrojejunectomy. Then why here anterior gastrojejunostomy is mentioned? The reason is the tumor in the stomach will be usually on the posterior wall of the stomach. If you see the statistics, about 60 to 70% tumors are on the posterior wall, only 20 to 30% there on the anterior wall. That is why the posterior gastrojejunostomy is technically not feasible. So when it's not technically feasible, then what you do? You do anterior gastrojejunostomy. But the problem with anterior gastrojejunostomy is you are going to have a long loop. The loop will have the postoperative sequelae. And the tumor has a tendency to spread on the posterior wall of the stomach. Anterior gastrojejunostomy is usually performed. A high gastrojejunostomy gives poor results as it may cause bile reflux. For example, the tumor is like this, in this place, causing obstruction. Then you have to do the anastomosis to the fundus of the stomach. When you do simple gastrojejunostomy to the fundus of the stomach, the drainage problem will be there because duodenal junction is here. From here, you have to take the bowel here and do the anastomosis. So this will pose a lot of problems with the efferent loops. So in this case, what you do is you do a simple Roux-en-Y gastrojejunostomy. You take the Roux-en-Y loop and anastomose to the fundus of the stomach. That will act as a diversion for the food because of to relieve from the obstruction. The tumor is there in the cardiac end of the stomach. It manifests with dysphagia. So you have to manage it by palliative intubation. You pass a tube through this tumor into the esophagus. Or keep a stent. Nowadays we have gastroendoscopy. So with a upper GI endoscopy, you can introduce a stent into the tumor tissue and keep it open by the stent itself. So these stents are specially made. They are called self-expanding metallic stents. So the self-expanding metallic stents, they always keep themselves open. Even the tumor try to infiltrate and press them, they resist that. So the lumen will be remaining patent for at least 3 to 6 months. Or you can do laserization. Laserization means you pass an endoscope, see the tumor mass in the lower end of the esophagus or at the cardiac end. So with the laser rays, you burn the tumor and make a tunnel. So by burning the tumor, you create a tunnel through the tumor into the stomach. So that is called laserization or laser tunnel formation. So in the olden days, what the surgeons used to do was they used to put a tube into the stomach and leave it outside so that the patient can be fed. But gastrostomy gives a lot of trouble to the patient. You can keep his nutrition, but the distressing symptom of dysphagia cannot be relieved. Why dysphagia is distressing? Because normally every individual secretes about 1.5 liters of saliva every day. So that saliva has to be swallowed. When there is obstruction, the patient cannot swallow saliva. Then what happens? There is a lot of drooling of saliva from the mouth. He cannot swallow, so that's why always saliva will be just drooling out. And there will be collection of saliva in the upper end of the esophagus. There will be collection of saliva in the pharynx, which can cause aspiration. That is why gastrostomy operation, that means leaving a tube into the stomach and leaving to the exterior for feeding purpose. So a feeding gastrostomy is indicated only to condemn it. You should not do that. Radiotherapy is useful in giving palliation from pain produced by the bone deposits. What is FJ? I cannot understand. Feeding jejunostomy. Okay, feeding jejunostomy can be given, but the problem for the patient with upper end tumors is dysphagia. The dysphagia is for the food and dysphagia for the saliva. So salivary dysphagia is more troublesome. The food dysphagia is there only 3 times a day, but salivary dysphagia is there every minute. So every minute he gets saliva, and the saliva what patient wants to swallow, that won't go inside. That pools. Whenever it cannot go drain, it will be there pooling. The pooling of saliva will be there in the throat, in the esophagus. So they will cause the aspiration problem. So feeding jejunostomy is also not advocated. Only the thing is, you do laserization with the help of laser, or you put a stent with the help of endoscope, or you do surgery and keep a tube inside. There are many number of tubes are available, so the tubes can be passed through the tumor and kept there to keep the lumen open. Then chemotherapy. So epirubicin, cisplatin, 5-fluorouracil. The results of chemotherapy are not encouraging. Japanese method. In Japan, because of high incidence of cancer stomach, those surgeons are well experienced in dealing with these cases, and they have early gastric cancer, which gives a long-term survival. So they usually, what they do is they do extended radical mastectomy. That means the radical gastrectomy itself is a radical procedure. So they will extend that. That means, for example, D1 gastrectomy means it is radical gastrectomy with stations 3 to 6 lymph nodes. That means nodes along the curvatures. If they are removed, it's called D1 gastrectomy. D2 gastrectomy. That means nodes along the vessels supplying the stomach, along the left gastric nodes, hepatic splenic, and hepatic hilar nodes. So when you remove all these things along with stomach and spleen, then you call this as D2 gastrectomy. D3 gastrectomy means nodes around the ordinal celiac and superior mesenteric arteries also are removed along with radical gastrectomy. So this D1, D2, D3 signifies whether first tier lymph nodes, second tier lymph nodes, third tier lymph nodes. The usual practice is D2 gastrectomy. Many of the surgeons, they practice D2 gastrectomy. Even surgical oncologists also, they prefer the D2 gastrectomy. Prognosis, the statistics from Japan and the West show different results. In Japan, they can do 75% curative resections. That means they have 75% of the cases are operable tumors. 5-year survival rate is about 50 to 70%. In the Western countries, curative resection is only 25 to 50%, and survival rate is only 25 to 30%. We too have the same type of results from the institutions. So that is about the carcinoma of the stomach. Then other types of malignant tumors. Leather bottle stomach, also called as the linitis plastica. Types generalized and localized. Localized is usually to the pylorocantrum. So you can see here the tumor. The tumor infiltrates in the wall of the stomach. Mucosa is absolutely normal. So there will be great thickening of the stomach wall. So this is called the infiltrative type. The stomach wall is enormously thickened and feels like a leather bag. The thickening is due to enormous proliferation of fibrous tissue as a response to the tumor infiltration in the submucosa. The mucosa appears quite normal. Because of the infiltration of the muscle coat and submucous coat with the tumor tissue and fibrosis, the muscle is largely replaced. So it has no normal peristaltic activity. So it is a fixed tube. So when you pour water or food, it can't be propelled forwards. So the patient feels distension, and later the patient vomits out. So the clinical feature is fits of pyloric obstruction. Radiology, when you look, already has shown you in the previous class, there is small stomach which empties fast without peristaltic waves and bury a meal. Endoscopy, you will see a small stomach and mucosa appears normal. The biopsy from the mucosa may not show the lesion because the lesion is mostly in the submucous coat and the muscle coat. So the biopsy from the mucosa will not be of help. Differential diagnosis of the Linitis plastica, Boeck's sarcoidosis, Crohn's disease, carcinoma of the pancreas invading the stomach. Treatment is total radical gastrectomy. Then the other type of gastric cancer is the colloid cancer. Incidence 6% of gastric carcinoma. The stomach wall is infiltrated by a gelatinous substance in all layers. So colloid carcinomas, they usually secrete the gelatin. It usually gives rise to Krukenbach's tumors. Treatment, same method of the leather bottle stomach. Prognosis is bad for these mucoid carcinomas. Gastric stromal tumors. Stroma means the mesenchyma of the stomach is called the stroma. That includes mostly the muscle cords. So the smooth muscle, if it becomes neoplastic, then we call it as stromal tumors. They were previously named as leiomyoma and leiomyosarcoma, and now it was observed that leiomyoma and leiomyosarcoma are not two entities. It is only one entity, that is the sarcoma. But why earlier it was called as leiomyoma? The reason is it is a well-differentiated tumor or low-grade tumor. So the sarcomas affecting the muscles of this gut, they can behave like a benign tumor, but they are not benign, they are malignant. Then there will be slow growth with encapsulation for some type of tumors. Once some type of tumors, they increase in size very rapidly and they disseminate very rapidly. So it can be at two extremes. So that is why they call it as leiomyoma and leiomyosarcoma, but of late it was observed that both belong to the same disease category, but one is showing little resistance and little spread, while the other one shows the faster spread. Incidence, the highest in the stomach of all the GIT stromal tumors. Pathology, unpredictable behavior. It may be subserosal or submucosal. It presents like a big mass arising from the stomach. Clinical features, there will be swelling in the epigastrium seen in subserosal tumors. Melena, dyspepsia, and pain occur in submucosal type tumors. Investigations, endoscopy and barium meal. Ultrasound or CT scan. Ultrasound is not much useful. CT scan will show you the size of the tumor and its infiltration as well as the liver secondaries. Large tumors, the treatment is gastrectomy. Small tumors, wide local excision. Chemotherapy, adjuvant therapy with imitinib is helpful. Gastric lymphoma. Types, primary, which arises in the stomach. Secondary, which is part of generalized lymphomatous process. I hope you know about lymphomas, Hodgkin's lymphoma. The Hodgkin's lymphoma is having 4 stages. Stage 1 means the disease is confined to the one region of lymph nodes. Stage 2 means it is there in 2 groups or more of lymph nodes. 2 or more groups of lymph nodes are involved. And these 2 or more groups of lymph nodes are situated either above the diaphragm or below the diaphragm. That means confined to the diaphragm. Then stage 3 means both above and below. Stage 4 means there is spread to the viscera, that means liver, the stomach, the bone marrow, the spleen. So all these structures may be involved in stage 4, that is visceral metastasis. So for example, a patient with carcinoma of the stomach comes to you. Stomach also has the lymphoid follicles in submucosa. Those lymphoid follicles, they can undergo lymphomatous change. If they undergo lymphomatous change and present as a mass in the stomach, then we call it as primary gastric lymphoma. But these lymphomatous masses are present along with lymph nodes elsewhere in the body. So there is lymphoma of the neck nodes, there is lymphoma of the inguinal nodes, like that. Then we call that as a secondary process, secondary lymphoma, due to generalized lymphomatous process. Why you have to make this distinction? If it is confined to the stomach, we can do radical gastrectomy or treatment for that. If it is disseminated one, is part of disseminated tumor, then you have to go for the chemotherapy. Cell of origin, B cell derived and arises from the mucosa associated lymphoid tissue. This is called MALT. The normal stomach is relatively devoid of lymphoid tissue, and in the presence of chronic gastritis, the stomach acquires this mucosa associated lymphoid tissue, which can undergo malignant transformation. H. pylori is the commonest cause for this chronic gastritis. The stomach is the most common site of primary GI lymphoma, and over 95% are non-Hodgkin type. 4%, it accounts for 4% of all gastric neoplasms. It is common in 6th decade. H. pylori infection is associated. Clinical manifestations are similar to that of gastric carcinoma. It can manifest like obstruction, bleeding, mass, or dyspepsia. There may be general features in lymphomas in form of fever, weight loss, night sweats. They are present in about half of the cases. Generalized lymphadenopathy suggests systemic disease. Of course, I will tell you more about this lymphoma when we talk about the lymph nodal diseases. Diagnosis, endoscopy and biopsy. You will find nodular lesion with enlarged and thickened mucosal folds. Diffuse infiltrations like litus plastica suggest secondary lymphoma. To evaluate whether it is primary or part of generalized lymphomatous process, you do CT scan of the abdomen and chest to see for the lymphomas in the chest, posterior mediastinum, or elsewhere in the abdominal cavity. Then bone marrow aspiration, then blood count analysis. Treatment of lymphoma, high-grade gastric lymphoma, chemotherapy, radiation without surgical resection. Most of the lymphomas, they respond well to radiation. Radical D2 gastrectomy may be performed especially for bulky tumors with bleeding and/or obstruction. Low-grade lymphoma, it is due to H. pylori infection and it usually regresses after H. pylori eradication. If low-grade lymphoma persists after H. pylori eradication, but disease is confined to the stomach, you have to give radiotherapy. For more advanced lesions, chemotherapy with or without radiation is advised. For systemic therapy, give chemotherapy. So this is how you plan your treatment for gastric lymphoma. So with it, we finished neoplasms of the stomach. Now we'll go to the neoplasms of the duodenum. They are classified into the benign and malignant. Benign is villus adenoma, then endocrine tumors, malignant adenocarcinoma. Villus adenoma occurs usually in the periampullary region, usually associated with familial adenomatosis polyposis. It is pre-malignant, hence should be removed. Endocrine tumors, gastrinoma, carcinoid tumors, rarely. Already we have discussed about the gastrinoma. So it occurs it arises from the G cells. They are situated in the gastrinoma triangle. So one of the contents of the gastrinoma triangle is the first and second parts of the duodenum. So it has G cells in the second part and first part of the duodenum. From the G cells, the gastrinoma tumors can arise. Really, the endocrine tumors can be due to carcinoids. Gastrinoma arises from G cells found in the Brunner's glands. They are present in the gastrinoma triangle. They manifest as Zollinger syndrome, and they may be associated with MEN type 1 syndrome. because we already discussed about Zollinger-Ellison syndrome and this gastroma triangle, I am not going to elaborate about these things here now. Malignant gastromas, they are rare, they metastasize to the liver. Duodenal adenocarcinoma, it is an uncommon site for carcinoma, but it's commonest site for adenocarcinoma arising in small bowel. When you look at the tumors of the stomach, the pyloric canal growth, for example, you see, the tumor spreads proximally, the tumor spreads distally. How far? Only up to the pylorus. Beyond the pylorus, it won't go into the duodenum. Why? The reason is not known. Duodenum is relatively immune to neoplastic infiltration and neoplastic occurrence. Even primary tumors in duodenum, they are very rare. So duodenum is a very uncommon site for carcinomas. But when you see the statistical data of all neoplasms arising in the small bowel, including duodenum, then duodenum has the highest number of carcinomas. The site of origin, common site is periampullary carcinoma. The precancerous lesions, villus adenoma, familial polyposis coli, then spread direct to the ampulla, pancreas, or retroperitoneum, to the local lymph nodes, and to the liver by blood spread. Clinical features, there will be anemia, asthenia, and dyspepsia. They produce obstruction of the duodenum, causing bilious vomiting with the visible gastric peristalsis. Then we have obstructive jaundice, so the growth invades the ampulla. Treatment, operable cases, you do Whipple's procedure, just like the pancreatic head cancers. Inoperable cases, palliative gastrojejunostomy or choledochojejunostomy if the patient develops the jaundice, intractable obstructive jaundice. So we are coming to the end of this class, so end of this chapter. The duodenal obstruction causes. Apart from the carcinoma of the duodenum, there are other causes like carcinoma of the head of the pancreas, which is the commonest cause. Then metastasis from colorectal and gastric cancer, primary duodenal carcinoma, annular pancreas following acute pancreatitis, and following chronic duodenal ileus. So all these conditions can cause obstruction of the duodenum. And here you don't know about the annular pancreas, and you don't know about the chronic duodenal ileus. So what is this annular pancreas? That means it is a congenital anomaly. Normally, the pancreas should be within the curve of the C loop of the duodenum. But during development, pancreas develops from a ventral bud and a dorsal bud. So two buds will be there. So on the ventral side there is one bud, and dorsal side there is one bud. Both develop into pancreas. And during 6th or 7th week of intrauterine life, both these they fuse. How they fuse? Ventral one and dorsal one, they can't fuse because one is ventral, one is dorsal. Then what happens? The ventral one, it rotates around the esophagus, around the duodenum, and goes behind and joins with the dorsal bud pancreas and forms into the pancreas. So while it is rotating like this, it differentiates into pancreatic tissue. So when differentiated pancreatic tissue, what will happen? Around the duodenum, like a ring, there will be pancreatic tissue. Normally, duodenum is free. There is no such structure around the duodenum. But when pancreas develops around the duodenum and forms a ring of pancreatic tissue, then that is called the annular pancreas. So that occurs at the level of the papilla of Vater. So what is the patient's manifestation? duodenal narrowing. So if a patient presents with bilious vomitings and visible gastric peristalsis. So this occurs present immediately after birth, or it may be there few months after birth. So that is annular pancreas. Then what is duodenal ileus? Ileus means obstruction, chronic duodenal obstruction. So there is an entity called chronic duodenal ileus. This is the one. This is also called as superior mesenteric artery syndrome. Why this chronic duodenal obstruction? It is due to compression of the third part of the duodenum between superior mesenteric artery and vertebral column. Now you can see here the superior mesenteric artery and vein, they cross in front of the uncinate process of the pancreas. Then it passes over the third part of the duodenum. The vertebral column is just behind this. Sometimes what happens, this will be producing tight stretching over the duodenum. So this artery, when it gets tightly stretched over the duodenum gets the obstruction. In this case, the duodenum is dilated up to the superior mesenteric artery. It's gross dilated because in any case where obstruction is there, proximal to the obstruction, there will be dilatation. Diagnosis is barium shows abrupt stopping of the barium in the third part of the duodenum. Treatment is duodenojejunectomy, anastomosis jejunum to the duodenum. So this is the barium finding. So when you give barium, the barium comes here and stops abruptly at the place where superior mesenteric artery crosses the duodenum. So this is the duodenal ileus. Any doubts, please? If you have no doubts, we will go to the other topic, the miscellaneous conditions of the stomach. Yes, when we anastomose jejunum with the fundus of the stomach, will there be any chance of bile entering the stomach? That is why what we do is we do the Roux-en-Y anastomosis. Anyway, I will show that Roux-en-Y anastomosis once again to you. Now see this anastomosis. This is the Roux-en-Y loop. This is like a Y. Food comes from this loop into the jejunum. Bile, it comes like this, and goes down like this. Because peristalsis will prevent the bile coming from this place to the upper side. So the bile won't enter into this place. So that is the advantage of doing a Roux-en-Y anastomosis. If you just take a loop of jejunum and anastomosity here, then the bile reflux will be there. But when you do Roux-en-Y anastomosis, this bile reflux will not be there. So the bile will go like this and it passes like this into the jejunum. So there is no question of reflux because this particular segment will be having peristalsis downwards. So it pushes water or bile comes, it will be just pushed down. That's why if you have a long segment of this one, the chance of this bile regurgitation is very less or absent. So if you do gastrojejunostomy between the fundus of the stomach and jejunum, if you do with Roux-en-Y loop, then there is no chance of getting the bile reflux into the stomach. Is it clear? Okay. Any more doubts? Are there any more doubts in the neoplams of the stomach? Okay, if you have no more doubts, we will switch over to the miscellaneous conditions of the stomach. The first condition is acute gastric dilatation. Acute gastric dilatation is a form of paralytic ileus. What is paralytic ileus? There will be absence of peristaltic activity of the small bowel. So whenever there is absence of peristaltic activity for the gut, how it manifests? Tell me. Either stomach or small bowel, if they has no peristaltic activity, just like a rigid tube, then what will happen? How the patient manifests in such a case? Yes, the patient manifests not only with bloating, distension, but also with features of vomiting. The vomiting is not projectile vomiting because there is no peristaltic activity. So the patient will get regurgitant vomiting. Mouthfuls of water and food will be coming into his mouth and he will be just vomiting it out. So the patient will have distension, retention of secretions inside the gut with vomitings. So that is the feature in paralytic ileus. So acute gastric dilatation also behaves in similar line. The causes being blunt abdominal trauma. So whenever abdominal trauma is there to the upper part of the abdomen, the stomach may go into the paralytic ileus. So whenever any part of the bowel is subjected to stretch, depending upon the severity of the stretch, it goes into paresis. That means if the mild stretch is there, the paresis will be there for about 6 to 10 hours. If there is a moderate stretch is there, it will go into paresis for about 1 day. If a severe stretch is there, it will be there about for 4 to 5 days or 7 days. What is the commonest cause of stretching of the bowel? What is the commonest cause for stretching of the bowel? Of course, abdominal trauma is one thing. What is the commonest cause? What is the commonest cause of stretching of the bowels? By taking food, it is not stretching, it is receptive relaxation. The bowel wants itself to gets relaxed. The bowel relaxes itself. It is not stretching. Stretching means some outside force is doing stretching business. Yes, iatrogenic. Someone has said iatrogenic. Iatrogenic means what? Can you explain it a little bit? What do you mean by iatrogenic here? Okay, I will tell. Whenever you do surgery on the abdominal cavity, what will you do? You explore. Is there any problem in the small bowel? Is there any problem in the colon? Is there any problem in the stomach? So what you do, you take the bowels and then do like this. So you see all the bowels. So when you are pulling it like this means you are stretching the bowel. You are holding it means you are stretching the bowels. So even for that holding, the bowels go into paralytic ileus. That is why after any laparotomy, the patients will have paralytic ileus for about 10 to 12 hours. That is minimum. If you have done some surgery for example, some anastomosis, so you have pulled it, kept it there, put a clamp there, cut it, suture it, do all that. That means there is moderate trauma. So there will be paralytic ileus for 2 days or 3 days. So the bowels won't contract. There will be stasis of fluid. There will be distension. There will be vomiting. So that is all normal following surgical procedure, following laparotomy. That is why after doing surgery for any abdominal case, when the patient is admitted in the ward, there will be Rayleigh tube in his mouth. So the Rayleigh tubes are through the nose. So the Rayleigh tube, the surgeon will be asked to see for the aspirations. So continuously you will be doing aspiration and supplementing with fluid. For 1 or 2 days you will be doing like that. Why? Because there is some amount of paresis of the bowels. So the commonest cause for paralytic ileus is post-surgery on the abdomen, post-laparotomy. So the lesson what you must learn here is, once you become abdominal surgeons, when you open the abdomen, you must be very gentle in holding the bowels and very gentle in exploring the bowels. If you are very harsh to the bowels, they will also be harsh towards you. That means post-operative period, they will show you nightmares. So we are talking about acute gastric dilatation. That means stomach loses its peristaltic activity and dilates into a large bag. These are causes are following blunt abdominal trauma, following acute pancreatitis, we have seen it. Then following surgery on the stomach, pancreas, spleen, hepatobiliary system, or retroperitoneum. So any surgery on the stomach or its neighboring organs that makes the stomach go into the dilatation. Then metabolic causes like electrolyte disturbances, renal failure, and shock. One electrolyte, either it is excess or low, it causes paresis of the bowels, including the stomach. Do you know that? Yes, very good, Shruti. It is potassium. Hypokalemia and hyperkalemia both cause paralytic ileus as well as acute gastric dilatation. Prevention: nasogastric aspiration in the patients prone to develop gastric atony. That means when a patient with acute pancreatitis comes to you, though there is no dilatation of the stomach, it is always preferable to put a Rayleigh tube and aspirate him. Once he develops dilatation and stasis, then the stretch will be amplified. So to prevent that stretch, what you do is you see that there is no retention of secretions or there is no presence of secretions in the stomach, you go on aspirating it. Treatment also is called the drip and suction. Drip means intravenous fluids. Suction means put an nasogastric aspiration. So the treatment for acute dilatation of stomach is drip and suction till the patient's stomach recovers. So I told you, following the stretch, if it is minimal, it will be recovering within 12 hours, moderate within 1 or 2 days, severe in 4 to 5 days or 1 week. If it is more than 5 days, if it is having atony, means there is some organic cause. There is not simple functional cause. There is some abscess collection, or there is some obstruction, or something abnormal is there. You have to investigate for that. Or there is persistent hypokalemia or hyperkalemia. So when you are doing a nasogastric aspiration, what you are removing? You are removing gastric secretions. Already we have seen that gastric secretions have high quantity of potassium. So the patients are likely to go into hypokalemia. Can you tell me how much potassium is there in 1 liter of gastric secretion? How much of potassium in 1 liter of gastric secretion? Wonderful, Manogya. I appreciate. You followed the class, yesterday's class very much. It is 10 milliequivalents. 10 milliequivalents of potassium is there per every liter of gastric secretion. Good, very good. Keep it up. The next condition is trichobezoar or phytobezoar. Sorry, not or, it is on. Trichobezoar and phytobezoar. Trichobezoar means it is ball of hair. Phytobezoar means it is ball of vegetables. So a ball of hair or ball of vegetables occur in the stomach. Cause is swallowing of hair by psychiatric patients, usually young females. Why not old psychiatric patients? Because they have sparse hair. Young females, they have long hair, and psychiatric patients, they swallow the hair. In chronic gastric stasis, there will be vegetable matter also become a mass and forms a ball. This is not the stomach. This is a hair ball removed from the stomach and duodenum. So one patient got distension and then pain abdomen. So he was operated. So a large mass is there in the stomach. So gastrotomy was made and this mass was removed. Of course, not by me, but someone else. So this is the mass. So this hair ball assumes the stomach shape. So just like casting. The hair ball causes obstruction, ulceration, or perforation. Investigation, upper GI endoscopy, berry meal, X-ray. Treatment, surgery, that is gastrotomy and removal of the bezoar. Foreign bodies in the stomach. All types of physical objects found on the earth can be a foreign body in the stomach. Presentation, usually asymptomatic, rarely as pain, perforation, or bleeding. Investigations, endoscopy. It is not only helpful in diagnosis but also useful in retrieving the foreign body with various forceps. Plain X-ray abdomen. So you can see here, plain X-ray abdomen shows a safety pin. Yes, upper GI endoscopy, when you pass, there will not be much space when hair ball is there. But when you inflate, you will have some space. Once you go into the esophagogastric junction itself, you will notice the hair ball. So you can find some space. Through that space, you can accommodate your scope, but with difficulty. You can see here in the X-ray abdomen, there is an open safety pin. Similarly, there is another foreign body here. Upper GI endoscopy can show you the foreign bodies like the coin. You can see the open safety pin. So you have various forceps to grasp these foreign bodies. So during endoscopy, what you do is, if it is a closed safety pin, you can leave it. It will pass out through the rectum and anal canal outside. But an open safety pin is always dangerous because the sharp end of this safety pin can penetrate some structure and can cause perforation and bleeding. That's why it should be removed. So you pass the endoscope, you observe this foreign body, then you pass a foreign body forceps, grasp it, and you retrieve the endoscope along with the foreign body and foreign body holding forceps. So everything will be coming out. The blunt object which leaves stomach passes out spontaneously and hence patient is reassured. So the treatment is or blunt objects. For example, a patient has swallowed a 50 paisa coin. It has passed through the cricopharyngeal junction easily. It is there in the stomach. So the parents are very much worried. The child has swallowed that, so please remove that. So if it is there in the stomach, you need not get panic. You can allow it to pass out through the intestines. It will take its time. it will be there out in 2 or 3 days or 4 days. If it is blunt object. If it is a sharp object, then you should remove it. What are the indications for endoscopic retrieval? Symptomatic foreign bodies, and if it does not progress down into the gut. Sharp or pointed foreign bodies. Over tube should be used for endoscopic retrieval of sharp objects to avoid injury to the esophagus and pharynx. In the next film, I will show you, next slide I will show you. If endoscopy is not successful, then you can do surgery and remove the foreign body. Laparotomy plus gastrotomy and removal of the foreign body. So for example, this patient has swallowed a blade like this. You pass a foreign body forceps, hold the blade. You can't pull this blade into the suction tube of the endoscope. You keeping it held like this, you take away the scope. So when the scope is taken out, then this object also will be coming out. When it is sharp, when it is coming out, it can tear the esophagus and pharynx. That is why there should be some protection for that. So what you do is you pass a tube over the scope, endoscope, and you slide this tube. This is called over tube. You slide this tube downwards. So what happens? This tube will come like this and enclose this foreign body. Then you remove the whole assembly. That is not going to injure the gut. So this is called the over tube. Volvulus of the stomach. What is meant by volvulus? Twisting. If some object twists on its own self, it is called volvulus. Stomach rotates along its horizontal axis or vertical axis between two fixed points, namely the cardiac end and pyloric end. It is usually associated with a rolling esophageal hiatal hernia. You can see here the stomach has rotated vertically. So there is a twist is there. Here is the twist. This is horizontal rotation where the stomach has rotated up. That means greater curvature has gone upside, lesser curvature has come to the downside. Clinical manifestations, when it occurs acutely, it is called Burkhardt triad. There will be acute epigastric pain, violent retchings, and inability to pass a nasogastric tube. In chronic cases, there will be dyspepsia and bloating sensation after taking small quantities of food. Investigation, barium meal is more helpful than endoscopy in these cases. If you give barium meal, you can see this is the greater curvature of the stomach, which has gone up like this. Treatment, laparotomy, reduction of diaphragmatic hernia, because paraesophageal diaphragmatic hernia is usually associated with such types of torsions. So reduce the stomach from the diaphragmatic hernia into the abdominal cavity. Repair the hernial defect by polypropylene mesh. And then fix the anterior wall of the stomach to the anterior abdominal wall so that it won't go into torsion once again. Then the other condition is the duodenal diverticulum. Diverticulum is a herniation of mucosa through the muscle wall of the gut or any other hollow organ. Primary and secondary, you can see here. This is the wall of the duodenum. This is the mucosa of the duodenum. This mucous membrane has passed out through a small defect in the muscle coat, and it came out as a projection, as a herniation. So this is called the diverticulum. So whenever there is a bulge from the wall of the gut outside, like finger-like process, we call it as a diverticulum. So in the duodenum, why diverticulum occur? it may be due to primary cause, that means where the defect is there in the duodenum, or it may be secondary to some other cause like duodenal ulcer healing. So when the duodenal ulcer heals, there will be fibrosis. When the fibrosis contracts, then there will be irregular pouchings of duodenum in between the scarring. So that gives the appearance of a diverticulum, though it is not a true diverticulum. That is what is called a pseudo-diverticulum. So here the primary diverticulum usually is single, sometimes multiple like this. They are present since birth and they commonly occur on the concave border. Why on the concave border? Because we have a blood vessel here in the curvature of the duodenum. That blood vessel gives off branches going through the wall of the duodenum at this border. So there is a small aperture in the duodenal muscle coat where the blood vessel goes in. Sometimes what happens is, by the side of this aperture, by the side of this blood vessel, which is perforating the muscle coat, the mucosa protrudes out and form these pouches. So these are the duodenal diverticula. So they occur in the concave border, second and third parts of duodenum at the entry of blood vessels into the duodenum. Can you tell me what blood vessels are here in the concavity of this duodenum? What are the blood vessels that are there in the concavity of the duodenum? Yes, Fatima is all right. It is superior and inferior pancreaduodenal, not only superior pancreaduodenal. It is the anastomotic arch between the superior mesenteric artery and the inferior mesenteric artery. Yes, very good. So vessels coming from this pancreaduodenal artery, they pass through the duodenal wall. So from the where they pass through that opening, this pouch of mucosa projects out. Usually they are asymptomatic. Sometimes they manifest with jaundice due to pressure by the parapapillary diverticulum. If this diverticulum is there, this diverticulum can press over the papilla of water or terminal part of the bile duct, producing obstructive jaundice. Secondary are due to scarring of the duodenum following duodenal ulcer. They cause trifoliate deformity on the Berry Mill X-ray. You can see this is Berry Mill X-ray showing this diverticulum here. This is one more diverticulum here in the fourth part of the duodenum, sorry, third part of the duodenum. If you do endoscopy, you can see these diverticular openings. So this is the mouth of the diverticulum. This is the mouth of the diverticulum. Then duodenal fistula. If there is abnormal communication between the duodenum and some other organ or skin, we call it as duodenal fistula. Causes duodenal bloat following gastrectomy operation. Traumatic rupture of the duodenum. You can see here, this patient underwent partial gastrectomy followed by gastrojejunal anastomosis. So when you do gastrojejunal anastomosis, little far off from the duodenojejunal junction, for example, this is the duodenojejunal junction. You have not done the anastomosis immediately next to the DJ junction, but you have done the anastomosis leaving behind few centimeters of the bowel and then did the anastomosis. So what will happen? If whenever you leave it like this, there will be long loop will be present here. So whenever this long loop is there, it gets kinked. You can see here it is kinked here, it is kinked here. So the patient takes food. After you do surgery, after third day or fourth day, the patient takes food. This food will go into this limb and go away. But whenever the food is there in the stomach due to psychic stimuli and other neuropeptide hormone secretions, the duodenum, pancreas, and bile also will be secreted into the second part of the duodenum. So there will be a lot of bile and pancreatic juice collection here. So that tries to go like this, but because there is a kink here, they can't go. So what they do, they will cause distension proximally. That means if there is obstruction here, then all these structures will be very much distended, grossly distended. So whenever this duodenum is distended, duodenum is already, it was transected and sutured here. This is only second, third or fourth or fifth day. The duodenum is distending. So what happens, because it's not yet completely healed, the duodenal wall gives way. So what happens, all the biliary and pancreatic secretions that are accumulated here, they will be pumped out. So this is called duodenal blowout. This duodenal fistula can follow traumatic rupture of the duodenum, or following rupture or incision of an abscess connected with the perforated duodenal ulcer. Sometimes the duodenal ulcer is very, very small. So small fluid leaks and there is leak closes because it's very just pinpoint like hole. So the fluid that is leaked out of the duodenum will be infected in 3 or 4 days time and forms an abscess. So this abscess is there just by the side of the duodenum. So the patient complains of fever, pain and all that. You do a CT scan, you will notice an abscess there. Then you make a bold incision there. So if the incision is made, means you are going to cause duodenal fistula for such cases. The other cause being reperforation of duodenal ulcer following surgery, then following endoscopic sphincterotomy, following surgery and the duodenum for stone removal by transduodenal sphincterotomy, surgery and the colon, surgery and the right kidney, they can injure the duodenum. So when the injured duodenum is there, if you don't suture it, that means you must recognize and suture it. If you didn't recognize, then the patient will have this duodenal fistula formation. Clinical features, there are leakage of bile and pancreatic juices from the abdominal wound, excoriation of skin around the site of discharge. There are molecular disturbances because of secretions have a lot of electrolytes and they are lost outside. There will be hyponatremia, hypokalemia, and acidosis. And there will be hypoproteinemia. Treatment, protection of the skin with a barrier cream. So this treatment is just like pancreatic fistula, what we studied few days before. Then subsuctional drainage of the fistula. Already I explained to you what's meant by subsuction when we talked about the pancreatic diseases. Then nothing by mouth and total parenteral nutrition or jejunostomy feeding till the fistula heals. So once you give rest to the stomach and proximal duodenum by feeding jejunostomy or by nothing by mouth and total parenteral nutrition for about a week or 2 weeks, the fistula will be closed. Octreotide can be given to suppress the secretions. Treat the primary cause. If the duodenal ulcer is there, you must treat the primary cause. Evaluate for any distal duodenal obstruction and release it if present. So this completes the topic on the stomach and duodenum. And just a few lines about management of morbid obesity, because this is also concerned with the gastric surgical procedures. So that's why I will just tell you a few points about this bariatric surgery. Nowadays this became very, very popular because bariatric means, baros means weight, iatric means management, bariatric means weight management. So nowadays we are seeing such type of people. So because of the change in the lifestyle, people are more addicted to eating. I say it is addicted to eating. So because of this, they become obese. Even if you advise them to restrict their food intake, the immediate answer from the patients will be, "Sir, I take very little. You are asking me to take too much little than that." So that is the psychological state of the obese patients. So whenever a obese patient is there, he always feels that he is eating very less. When one feels that they are eating less, what they will do? They eat more. So that will add calories to their body and add fat to their tissues. So that is how this obesity is generated. Of course, there will be endocrinal hormone imbalance may be there. What is morbid obesity? One who is more than 100% of the normal body weight as per age, sex, and height, or one whose body mass index is more than 45. Mass index means weight in kg by height, square of the height in meters. Normally is 18.5 to 25. Overweight means 25 to 30. Obese means 30 to 45. Morbid obesity means is more than 45. Surgeries for morbid obesity. In the past, wiring of the jaws, interdental wiring used to be done, and patient is allowed to take only fluids. So the wiring will be kept there till the patient loses his weight. Or gastric bypass or small bowel bypass was done. These surgeries are not done nowadays because of the associated complications, but they are done in a modified way. Procedures done at present are, of course, this is also not being done. The lap band procedure, gastric bypass, and gastric resection. Indications: morbid obesity. You must exclude endocrinopathy in these obese patients. Then you must first give them the medical methods under medical supervision to reduce body weight by prescribing the patient proper exercise schedule as well as diet schedule, and see that the patient has followed them rigorously, and if they fail, then you must go for the surgical treatment. But nowadays this is not happening. So the patient himself decides to have surgery. They don't have time to go for lifestyle modification and diet modification. So they think that by getting surgery, they will lose weight with their normal intake of food. But that will never happen. All these things, they cause either malabsorption and loss of weight, or they cause storage problem to the stomach and they can't eat well. So the physiological basis of surgical management is ghrelin. Already I told you about this ghrelin. A growth hormone secretagogue is synthesized predominantly by the stomach. It levels rise just before meals and before prolonged starvation. It is an important orexogenic, that is appetite stimulating agent. Ghrelin levels normally fall rapidly after meals. After gastric bypass or resection surgery, ghrelin levels fall and do not increase before meals. So because you are removing large part of the stomach, the ghrelin production gets decreased. So the patient doesn't have the appetite signal. Low levels of ghrelin and its metabolic dysregulation may be partially responsible for the sustained weight loss after this morbid obesity operations. So we do procedure to produce malabsorption, or you restrict the food intake into the stomach by making it small, very small, not small, by making it very small. So the procedures being lap band procedure. What you do here is, this is an artificial device. So this is just like a flat band connected with a pipe. So what you do is, you place this just below the esophageal junction. so that this part of the stomach will have only about 30 to 40 ml capacity. So you keep it there and tighten it so that it forms a groove or constriction here, and this will not expand. So whenever the patient takes meal, that meal fills this particular pouch of stomach, and patient feels that he gets satiety. That means, okay, my stomach is full, I want to eat. So that type of feeling the patient gets because of this small stomach here. So this works on the principle of reduced food intake into the stomach. So an inflatable cuff is placed just below the OJ junction laparoscopically, and the band is inflated. The second type of procedure is called the gastric bypass operation. A proximal gastric pouch is made and is disconnected from the rest of the stomach. So you just cut the stomach, just leaving behind only a gastric pouch, which with the capacity of only just a 2 liter, with about 60 or 70 ml of fluid. Then do a Roux-en-Y anastomosis. So whenever the patient takes meal, this gets filled, so the patient gets satiety feeling, and the food will be drained like this into the jejunum. The next procedure is called sleeve gastrectomy. Here the great curvature side of the stomach is resected, leaving behind a sleeve of stomach along the lesser curvature with a diameter of only 11 millimeters. This procedure is performed laparoscopically. So you can see here, this is the normal stomach. Now the stomach is resected and only the small tubular stomach is being left behind. So the major part of the stomach has been removed here. That's why its hormone secretions has come down. And of course, much of the parietal area also is removed here. So with that, the patient will get into some malabsorption syndromes, as well as because of the removal of pernicious, parietal cell area, the patient gets anemia also. The effect of bariatric surgery, the following conditions show 70 to 85% improvement or they are resolved. Hence, these bariatric procedures are also called as metabolic surgeries. So diabetes mellitus type 2 can be cured by this particular procedure. Hypertension, sleep apnea, hyperlipidemia can be controlled with the bariatric surgery. Because once the obesity is controlled, so automatically the related diseases also will become controlled. So this is about the chapter on disease of stomach and duodenum. So we are left with only one more topic, that is complications of gastric surgery and sequelae of gastric surgery. If you have no doubts, we'll go to that particular topic. Any doubts? Okay. Yes, after doing gastric bypass, the distal part of the stomach will be functioning. It will be secreting secretions, and secretions will go into the duodenum. From there, they pass into the jejunum. But food won't come there. Food won't come there. So the idea of doing this gastric bypass is you make a small proximal pouch. It is directly anastomosed to the jejunum. So whenever the patient takes meal, this pouch is filled. So when the pouch is filled, then patient feels that he got a lot of satiety. So he will stop taking meal. So that means his food intake will be drastically reduced. So this will lead to the reduction of obesity. it will be stimulated because of psychic response, because it's eating and chewing and all that. It will be stimulated, and then you will get hydrochloric acid secretion. That's why what you do is you give the patient proton pump inhibitors along with all vitamins and minerals, because these patients, they will have a lot of malnourishment. The vitamin absorption is impaired, the mineral absorption is impaired, so that is why you have to supplement those things either orally or parenterally. No cutoff peristalsis, because stomach is having the enteric nervous system with various pacemakers there. Though you transect the stomach, from the cut end itself, the stomach can undergo peristalsis. It is not totally dependent upon the proximal pacemaker to control its peristalsis. Even if you cut a small bit of stomach, both proximal and distally, make it a small tube, that also will have peristaltic activity. So complications and sequelae of operations on stomach. Complications of gastric operations. They are classified as general complications and local complications. General complications being the cardiac, the thrombotic complications, pulmonary complications, and septic complications. Then anesthetic complications. Then specific complications specific to the stomach and duodenum. They are classified as early and late or remote. Early means occurring in the first 1 week after surgery. Late means 2 or 3 weeks after surgery. Early complications, you can remember this by remembering this point: bleed, leak, block. So these are the 3 problems the patients will face immediately after surgery in the early period. Bleed means hemorrhage from the anastomotic line. Leak means duodenal blowout following gastrectomy operation. Block means there is obstruction. The obstruction in the intestines can be due to paralytic ileus, due to stomal obstruction. There may be acute postoperative pancreatitis. Remote complications being, or late complications being, recurrent ulcer, gastrojejunocolic fistula, intestinal obstruction, post-gastrectomy syndromes or sequelae, and nutritional deficiencies following gastrectomy operations. Hemorrhage from the anastomotic line. So whenever you do gastrectomy operation or simple gastrojejunostomy operation, you cut the stomach and jejunum and open the openings. For example, you make an opening of this much. So what you do, you make an opening of jejunum also that much, and then you suture the borders together. Occasionally there may be bleeding from this sutured area. So it clinically manifests as presence of blood or altered blood from nasogastric tube. So in the postoperative period, after doing surgery on the stomach, you leave behind nasogastric tube. And in the ward, you will be aspirating once in every 15 minutes. In the initial few minutes, that means for first 2 or 3 hours, there will be some amount of blood coming in the aspirate. But after 3 or 4 hours, there should not be any blood in the rails tube aspiration. If it is containing large amount of blood is coming out, means the anastomotic line is bleeding. If it is mild, you can go with conservative measures. That means you maintain fluid balance, and then if patient is lost blood means give him blood transfusion. If it is severe means you have to reopen the abdomen and then you find the bleeder and underrun the bleeder. Duodenal fistula or blowout. It is rare, occurs after Billroth 2 gastrectomy due to duodenal stump leak or blowout. It occurs between 3rd and 5th days. Clinical manifestations: intense pain in the upper abdomen and lower chest, sometimes mistaken for pneumonic consolidation. If a drain is kept, so through the drain there will be flow of bile. There may be associated periodic ileus and peritonitis due to biliary leak into the peritoneal cavity. Prevention: to avoid operating on duodenum with active ulcer. If ulcer is active, so don't cut the duodenum and suture it, because it will be acutely inflamed. Acutely inflamed structures will be having edema. The edema will produce a lot of friability. So you should avoid doing surgery on such cases. The gastrojejunal stoma should be constructed in such a way that there is no kink or undue sag of efferent loop. So this is called the efferent loop. So this is the efferent loop and this is the efferent loop. The efferent loop should not be sagged. That means there is no loop formation. If a loop formation is there, that will lead to the duodenal blowout by distension of the duodenum. So see that there is no kink or no undue sag of the efferent loop. It should have a comfortable lie. Treatment: once you find that, you have to do laparotomy, do peritoneal toilet to wash out all biliary drainage, and put a sump drain at the site of the blowout. Manage it like duodenal fistula. There is nothing by mouth and total parenteral nutrition till the drainage of the bile from the sump drain stops. You can ask me, why can't you just suture the blown out duodenum? So that will be very much edematous and friable. So even if you try to suture it, it will cut through. That's why you don't go for attempting to suture any opening in the intestinal tract after 3rd or 4th day of operation. If you done operation today, the patient manifests usually on 3rd day or 4th day. The bowels will be very edematous and friable during that time. So if you try to suture the rent in the bowel, then they will just cut through. So a 1 centimeter incision or wound will become a 5 centimeter wound. So you should not try to attempt to do the suturing. So what you must do is just keep a drain there, some drain. Do laparotomy and peritoneal toilet and then keep a some drain, that's all. And manage the patient with total parenteral nutrition and nothing by mouth till the duodenal leak heals on its own. Then post-operative periodic ileus. Cause, I told you physiologically there will be periodic ileus for 2 days or 3 days. If it is prolonged, that means that there is something else in the periabdominal cavity. This something else can be due to sepsis, due to leak of due to anastomosis, or there is large blood clots in the peritoneal cavity. During surgery, you have caused some bleeding from the gut while you are suturing or while you are doing dissection. And all that blood must be evacuated from the peritoneal cavity. If you leave behind those blood clots in the peritoneal cavity, they will cause the periodic ileus. The periodic ileus can be due to electrolyte disturbance. Already I told you about hypokalemia and hyperkalemia. Treatment: the cause identified and rectified. Till that time, drip and suction, that means intravenous fluids and nasogastric aspiration. Stomal obstruction. What is meant by stoma? When you do gastrojejunostomy, the opening between the stomach and jejunum is called stoma. Actually, stoma means mouth. But when you do anastomosis, you call it as a stoma. Stomal obstruction. So what you have made the opening between the stomach and jejunum, that gets obstructed. That is stomal obstruction. Causes stomal edema. In the postoperative period, there will be a lot of edema which may cause obstruction. Or it may be due to a condition called retrograde jejunogastric intussusception, due to hypertrophic mucosa or due to atonic stomach, due to technical factors. When you don't follow these proper rules of gastrojejunostomy, that means no loop anastomosis, posterior wall, vertical, isoperistaltic, then the problems will be very less. If you don't follow those rules, it can lead to this stomal obstruction. Stomal edema usually follows Billroth-1 operation during first 5 days and rarely after Billroth-2 operation. Then retrograde jejunogastric intussusception. What is intussusception? Intussusception means if one part of the intestine gets telescoped into the other part of the intestine, it is called intussusception. Normally, the proximal, for example, this is the proximal end, this is the distal end. The proximal part of the small bowel will invaginate into the lumen of the distal bowel and it progresses like this. When it progresses, what will happen? It results in obstruction, intestinal obstruction. After you do gastrojejunostomy, because of the irritant acid that is coming into the jejunum, sometimes what happens is it produces acid. This acid will come into the jejunum like this. By this, jejunum gets irritated. So by that, it gets altered peristaltic activity. So because of this altered peristaltic activity, sometimes there will be this reverse intussusception. That means intussusception of the distal segment into the proximal segment. So this gets invaginated here and goes into the stomach. And there will be constriction at this place, causing obstruction. This occurs after gastrojejunostomy and usually manifests immediately or sometimes few months later. Investigation: filling defect is discovered on berry meal. Then endoscopy. Treatment: reduction by saline gastric lavage. What you do is, if, for example, this is following gastrojejunostomy. You put a Ryle's tube and then fill the stomach with 2 to 3 liters of fluid or saline. The saline will cause hydrostatic pressure over this bowel, and this invaginate bowel gradually gets retreated out. If it is not successful, you have to reduce it after laparotomy. Do laparotomy and then pull out the bowel which was invaginated slowly from this bowel and remove it. The other cause of stomal obstruction is hypertrophic mucosa. This occurs following Billroth-1 operation due to hypertrophy of the antral mucosa. Treatment is excision of that hypertrophic mucosa. Then other complication after surgery, which is a remote complication, is intestinal obstruction. This obstruction can be due to hernial obstruction or it can be due to bolus obstruction. Herniation obstruction means herniation of small bowel loop through the rent in the mesocolon following gastrojejunostomy. Did you see any gastrojejunostomy operation? Did you ever see gastrojejunostomy operation? Okay. All of you have seen Okay, do you want me to show one video clipping on gastrojejunostomy? Okay, then I will do one thing. I will stop these complications topic here, and now I will show you a video clipping on gastrojejunal anastomosis procedure. Then you can follow this herniation obstruction. Otherwise, you can't understand herniation of bowel through the rent in the mesocolon. So you cannot understand this. So that's why now I will show you the video clipping. Then we'll go ahead with these complications. If time permits, I will tell it now, or else I will tell it tomorrow. Okay? So just I will show you the gastrojejunostomy operation, how is it done. Before I tell you about the gastrojejunostomy anastomosis, first of all, I will tell you about something about intestinal anastomosis. When you resect the intestine and anastomose the bowel, how it gets united and what problems will be there and how these problems will be overcome. So whenever you are anastomosing two segments of the bowel together, the patient may have these problems. There may be bleeding from the site of the anastomosis, because these are all very vascular structures. There may be leak from the site of the anastomosis. There may be block due to kink or stomal obstruction. So in the initial days of intestinal anastomosis, the surgeons faced these problems. Gradually, they improved the technique to tide over these problems. Bleeding can be controlled by making all-coat continuous suture. All-coat means stomach or intestines have 4 layers: mucosa, submucosa, the muscle coat, and serous coat. So you take a bite through all the coats of stomach and take the bite of the needle through all coats of the jejunum, and do it like that continuously. So with a continuous stitch. So when you break the stitches for each stitch, that's called interrupted stitch. But when you do a continuous over and over suturing, means it is called a continuous suture. So when you do over and over suturing, what happens? Each will act as a loop. So within the loop, any bladder is there that gets occluded. So this is called continuous suturing. So with continuous suturing of the all coats together, it will lead to prevention of the bleeding from the stoma. The leak can be prevented by seromuscular inversion suture. What is seromuscular inversion suture? I will tell you. Bowel, when they are anastomosed, now suppose this is a bowel, this is bowel. You anastomose these two together. When you just anastomose it like this, first initially what they did was they did the experiments in the dog. They took the dog intestine, they just cut it and then just approximate it like this. and sutured. After suturing, what they did was they put a tube into the intestine and pumped in air and checked whether air leak will be there or not. Even with little air insufflation, there was leak when anastomosis is done just edge to edge. Then what they did was they did anastomosis in such a way that the edges are being everted after the anastomosis. For example, this is the intestinal tube, and this is another intestinal tube. And when you do the anastomosis, you do in such a way that edges gets everted like this after anastomosis. That means the edges will be, intestinal edges will be like this. So this is the intestine, this is the intestine. So you suture it in such a way their edges pout out. So their edges pout out. So that is called the everted anastomosis. So if the edges are everted, then if they inflate, then the leak is still more. Then what they did was they did the inversion type anastomosis. That means the edges are folded in like this. That is called inverted anastomosis. So seromuscular sharing, seromuscular inversion. If you do seromuscular inversion, the leak will be controlled. The block can be prevented by fashioning of proper and adequate stoma. So all core suture means you suture the all layers of the stomach with all layers of small bowel with a continuous suture. This is for the control of the bleeding. So this is called the hemostatic suturing. After doing this hemostatic suturing, then what you do is you give an additional row of anastomosis. That means you have an additional row of suturing. Your suturing must be like this. You take the bite not at the anastomotic site, just 1 centimeter away from it. You take the bite from the stomach at 1 centimeter proximal to the anastomotic site and take the bite from the jejunum 1 centimeter just distal to the anastomosis. Now pull them together. If you pull them together, what will happen? This gets inverted like this, this gets inverted like this. This is called the inversion. So the suturing of the outer, so there are two layers of suturing. An inner layer of all coat suture for the all coats, and outer layer of suturing, but this outer layer of suturing is not through all coats. It is only from the serous coat and part of the muscle coat. That is what is called seromuscular suturing. So seromuscular suturing for the outer coat, that is for the inversion of the anastomotic site. So an inner all coat suture, outer seromuscular coat or outer seromuscular suture. This is procedure what you follow in intestinal anastomosis. So any intestinal anastomosis usually is performed by the two-layer technique. An inner all coat layer of suturing and outer seromuscular layer coat of suturing. Did you follow this? Okay. So the anastomosis can be from end to end of the cut to the end of the cut, end of the other part of the bowel, or to the side to side of the bowel to the side of the bowel. This is it. end of the stomach to the side of the stomach, side of the small bowel. This is called the end to side anastomosis. And gastrojejunostomy, it is side to side anastomosis, side of the stomach to the side of the jejunum. So with these basic principles of intestinal anastomosis, let's come to the gastrojejunostomy. Operations it is advocated in peptic ulcer disease in combination with vagotomy, and also in inoperable carcinoma of the stomach, we have just now seen. In volvulus of the stomach, of course, is not being done nowadays. Types: open method by laparoscopic method, anesthesia general endotracheal anesthesia, incision midline or left paramedian incision. You can do it through right paramedian also if it is done alone. But when you are doing it along with vagotomy, means you must go with midline incision or left paramedian incision. Method of anastomosis: posterior or anterior. Posterior, we do the posterior vertical retrocolic isoperistaltic no loop gastrojejunostomy. Already I have discussed about this. Then the anterior is done in the malignant disease of the stomach. This is the posterior one, this is the anterior one. So now the stomach will be like this. Greater momentum is hanging like this. You have to go to the posterior wall to do the anastomosis between the stomach posterior wall and jejunum. So here this is the greater momentum. This is the posterior wall of the stomach. This is the transverse mesocolon, and here is the transverse colon. And these are the loops of the small bowel. So you must get this small bowel to the posterior wall of the stomach. And now you can see the greater momentum. It hangs from the greater curvature of the stomach, goes downwards, turns again upwards, and it is attached to the transverse colon. So how to get the jejunum to the stomach posterior wall? If you want to go like this, greater momentum has to be cut, and you must find space between the stomach and transverse colon and get the loop like this and anastomose it like this. So then you must have a very long efferent loop which will predispose to duodenal blowout or the vomitings, etc. You must have a close approach. That means the stomach should be anastomosed to the jejunum just beyond the duodenojejunal junction. So duodenojejunal junction is here. So you must anastomose it approximately here. So how to go to that one then? Here the transverse mesocolon. So what you do is you make an incision in the transverse mesocolon. You make a rent in the transverse mesocolon about 3 inches long. Transverse mesocolon is nothing but 2 leaves of the peritoneum, having the blood vessels going to the transverse colon. So just lift the transverse colon and see the avascular area where there are no blood vessels. At that place, you make an incision in the mesentery. And through that opening, you anastomose the stomach to the small bowel. So take the small bowel there to that opening, do the anastomosis. So that is how you do the posterior gastrojejunostomy. So that should be done through the transverse mesocolon. I hope you understood this point. Is it clear? Okay, that's fine. So how to go to the transverse mesocolon? You lift the greater momentum upwards and pull the transverse colon upwards. So when you pull it, so this is the transverse colon in your hand. Now what you are seeing here, this thing is the transverse mesocolon. And here is the small bowel. So this small bowel has to be anastomosed to the posterior wall of the stomach. The intervening, something like a septum is here, that is transverse mesocolon. So this is the transverse mesocolon, and this is the transverse mesocolon. So make an incision where blood vessels are not there. So it becomes vowel automatically. Through that, you pull out a fold of stomach outside. So you pass tissue forceps, hold the stomach posterior wall, drag it down. You apply stomach tissue forceps at this lesser curvature side and drag it out. So you will get a fold of stomach herniating through this transverse mesocolon opening. Keep it aside this jejunum and do the anastomosis between these two. I will show you. This is stomach, this is small bowel tube. So this light blue or cyan colored is the stomach. So through the small transverse mesocolon opening, you pass a Alice forceps or Babcock's forceps, hold a fold of stomach posterior wall, below and above. So this is the fold of stomach. To this fold of stomach, you apply a clamp. This is called an occlusion clamp. That means it just occludes, but it will not crush the tissues. That means the muscle wall is not damaged. It only occludes the lumen. Then take the small bowel and keep it aside. And for that also you put a clamp so that a fold of jejunum will be there by the side of the fold of the stomach. So you have two folds. One fold is that of the stomach, other fold is that of jejunum. So you suture them together. The fold of jejunum is sutured to the fold of the stomach by a continuous stitch. After they are sutured together, then you make an opening in the stomach. You make an opening in the jejunum. Okay? First you made the one continuous suturing here. Just by this 1 centimeter by the side of the sutured line, you made an opening in the stomach fold. You made an opening in the jejunal fold. So this fold is having, this is vowel. This is vowel. So this has two layers, an inner layer and an outer layer. This is also having inner layer and outer layer. Inner means nearer to the suturing line. So what you do? You suture this inner layer first. Then you suture the outer one to the outer one. Then outer one to the outer one. That becomes the anastomosis. So the anastomosis is completed. Then what you do is, the first suture line, what you have done, the same thing is again used to close the outer one here. That is, you are achieving seromuscular inversion. So our intention is, you have two folds of bowel. One fold is stomach. So there is one fold of stomach and there is one fold of jejunum. You keep these aside. First you suture them by a continuous suture. Then so this is the stomach fold, this is the jejunal fold. First you make a continuous suture between these two folds. Okay? Then you make an incision in the stomach fold, you make an incision in the jejunal. So you have an opening here, you have an opening here. This edge is sutured to this edge by a continuous stitch. With the same stitch, the cut edge of this edge, the cut edge of this edge are sutured together. So this will come like this. So the first one is the seromuscular suture. The second one is the all-core suture. The all-core suture is continued onto the edge, onto the outer edge. That means that becomes the third layer suturing. Then you have the fourth layer, that is again seromuscular. So two will be on one side, two will be on the other side. So ultimately this anastomosis will be there. So you can see here, transverse mesocolon is incised, a loop of stomach is drawn outside. No, you can see here, you will understand better, I think. So this is the fold of stomach, this is the fold of the jejunum. Both of them are kept side by side. And now a continuous suture is placed between these two bowel loops. This is the stomach, this is the jejunum. So this is the continuous suture between these two folds of stomach and jejunum. We don't remove this suture will be there. So this is the first suture. This first suture is seromuscular suture. That means the suture bite is taken from the serous and muscular coats only. So it is a seromuscular continuous suturing. Then just 1 centimeter away from this suture, you cut the stomach fold. Then you cut the jejunal fold. So you cut them. Then you have made one seromuscular suture. This is the seromuscular suture that is kept at side. That's first one. Then you take the second row of suturing. This is second row of suturing of the inner edges. The same is continued and then it made into the suturing of the outer edges also. Okay. So this inner edge is sutured by all-core suturing. That means through and through you suture it. Through and through you suture it like this. Once you come to the edges, again take the bite through and through and suture this. Okay. So now you have all-core suturing for the inner side and outer side. Seromuscular we have made only on inner side. Outer side we have not made. So now you make the outer side seromuscular suturing. So the first one is inner, first starting one is the seromuscular suturing. Then you make the openings in the stomach and jejunum. Then the inner parts of the cut edges are sutured continuously with all-core suture. And then outer edges are sutured by all-core suture. After finishing that, you will have again one outer seromuscular suturing. This is the outer seromuscular suturing. Is it clear? So this is the finished anastomosis between the stomach and jejunum. So you have pulled out the stomach through the rent in the mesocolon, transverse mesocolon. Now if you leave it like that, what will happen? The stomach will be dragged through the mesocolon and jejunum will herniate and cause obstruction. To prevent that, what you do? To the edge of the stomach, you suture the rent of the transverse mesocolon. So the stomach will be staying outside the transverse mesocolon and jejunum will not go and will not get herniated. So this is the closing of the transverse mesocolon rent. So this is gastrojejunostomy. I hope you understood this. Anyway, you open your operative surgery textbook and then read this. Tomorrow I will show you a operative video photograph, video of the gastrojejunostomy. How you do video jejunostomy, gastrojejunostomy. I will show that video to you in the tomorrow's class. Then you will have a better understanding. So please open your operative surgery textbook and then just go through the images as well as read the procedure of gastrojejunostomy. You will understand the outer seromuscular coat, inner all-coat layer. Then transverse mesocolon rent and closure of the transverse mesocolon rent to the edges of the stomach. or to the walls of the stomach. Okay? With this, I will stop this session today, and tomorrow we will have that video, and later I will continue with the sequelae and complications of gastric operations. Then we will have about half an hour time at the end. So in that half an hour time, what I will do is I will show you some cases. Lump in the epigastric region, because we have finished the pancreas and stomach and liver. So I will show you some cases. A lump in the epigastric region, a lump in the right hypochondric region. I will tell you the case history. Then I will ask you some questions regarding that case, how you proceed with the examination, how you arrive at the diagnosis, and how you manage that particular case. So there is nothing but a clinical case discussion. So depending upon the available time, we will have 1 or 2 or 3 cases. So for that, what you should do, you must come prepared for the topics of liver, stomach, and pancreas. Okay? Is it okay, or do you want it to have at some other time? Because anyway, we have completed these 3 topics I used to have tomorrow. So whatever time that is permissible for us, we will go ahead with the case discussion. Okay. So majority of you are opting for the case discussion. So we will have the case discussion. So but the thing is, only when you participate in the case discussion, then only it will be lively. If I am just telling the case findings, examination findings, then diagnosis, then investigations, then it is just like another boring lecture. So you must break the boring by your interaction. So you can do a better interaction if you know about the topics well. So please spend today evening and tomorrow morning, because you are still locked down, so you need not go outside. So utilize this time for brushing these topics again. And tomorrow we will have the discussion. If you want to have some more case discussion, we will continue it in the next classes also. No problem. Okay? Any doubt? Any doubt, please? Okay. See you tomorrow. Wish you all good night. Thank you.